Welcome to this brief tutorial on attention bias modification, ABM, in the treatment of anxiety and PTSD. ABM is a class of interventions targeting aberrant attentional processes identified as key in the etiology and maintenance of anxiety and stress-related disorders. The tutorial is designed to provide clinicians with a basic understanding of the theory and data behind ABM, and practical guidance on how to implement ABM in clinical settings. The provided ABM software runs using a Chrome browser and requires a functional computer and internet connection. Let's get started. At any given moment, the human brain is capable of perceiving countless stimuli in the surroundings. Due to limited capacity of the brain, further detailed processing takes place only for a select subset of stimuli. The attentional system is responsible for filtering and prioritization functions, determining what stimuli are more deeply processed at a given moment. One criterion according to which the attentional system selects relevant stimuli for further processing is the extent to which a stimulus is threatening. Of course, in the case of an actual danger, this prioritization of threatening stimuli is adaptive and critical for survival. But what happens when we encounter mild threats, or stimuli that represent something negative but not actually dangerous? Should we focus on them at the expense of other information? We use the term attention bias to threat to describe the tendency to overfocus on mild threats in the environment, such as words or images representing danger or threat, over benign stimuli. Attention bias to threat is manifested in detecting mild threats faster and taking longer to disengage from them. Heightened attention to threat, sometimes referred to as threat-related attention bias, may cause individuals to miss other, not threatening, information, potentially important for their normal and adaptive functioning. It may also create an overall experience of a more threatening environment. Experimental evidence shows that individuals diagnosed with anxiety disorders tend to exhibit greater attention bias to threat than non-anxious individuals. Relative to healthy controls, patients with PTSD demonstrate both increased attention bias to threat and greater variability in attention bias, reflected in fluctuations between overly attending threats and avoiding threats. ABM treatment for stress-related disorders is designed to target attention bias to threat. By modifying patients' information processing patterns into more adaptive ones, ABM can relieve patients' symptoms. This can be achieved using repetitive computerized training. The computerized task used in ABM is called dot probe. In the dot probe task, a spatial rivalry for patients' attention is created by presenting neutral and threat-related stimuli simultaneously. Following a fixation cross, pairs of threat and neutral stimuli are presented for a brief time, followed by an arrowhead appearing at either the location of the neutral or the threat stimulus. By clicking the keyboard buttons, patients are requested to indicate as quickly and accurately as possible if the arrowhead points to the right or to the left. In ABM for anxiety disorders, the arrowheads appear always or most frequently at the location of the neutral stimulus. This contingency implicitly encourages patients to orient away from the spatial location in which a threat stimulus appears. That is, attention is implicitly trained away from threat. In PTSD, training attention away from threat is also clinically effective. However, it has been suggested that because attention bias variability is also elevated in PTSD, an attention training approach that encourages a balanced attentional focus between neutral and threatening stimuli may also be clinically useful. This is accomplished by presenting the arrowhead probe at the location previously occupied by the threatening stimulus on 50% of the trials, and at the location previously occupied by the neutral stimulus on 50% of the trials. This variant of ABM is called ACT, Attention Control Training. Although ABM/ACT protocols differ in the number of training trials delivered per session and in the total number of sessions, ABM treatments are usually brief. The most common protocol delivers 150 to 200 training repetitions per session, taking 5 to 8 minutes to complete. The typical protocol consists of 8 sessions delivered twice weekly over a period of 4 weeks. It is recommended to allow at least a day between treatment sessions to allow for proper consolidation of the trained contingency. Research indicates that these intervals between sessions are important for learning consolidation. Randomized controlled trials show that ABM treatment is effective in reducing anxiety and PTSD symptoms. The figure presented here summarizes several ABM studies with anxiety disorders, taken from a meta-analysis published in 2010 by Hakamata et al. Most studies indicated significant clinical efficacy, with an overall medium effect size. More recent meta-analyses indicate similar clinical effects for ABM with anxiety disorders. This figure presents the results of 8 studies of patients with PTSD. Attention Control Training, ACT, protocols were designed to balance attentional focus between neutral and threatening stimuli. An overall large combined clinical effect size was noted. In addition to their clinical efficacy, ABM and ACT possess 2 important advantages. First, with relatively low dropout rates, the treatment is well tolerated relative to more demanding psychosocial interventions. Second, the dissemination of ABM and ACT is easy and simple. A standard computer, internet connection, and a quiet setting suffice. These advantages make ABM an attractive treatment for patients with anxiety disorders and PTSD. ABM or ACT can be used in the clinic as standalone treatments and can also be used with patients who do not show sufficient improvement with other treatments. Alternatively, ABM and ACT can be combined with other treatments. For example, studies indicate that combining ABM with personal cognitive behavioral therapy or group CBT results in better clinical outcomes compared to CBT alone. We now move forward to explain practical considerations when applying ABM or ACT. First, it is important to verify that the patient falls under one of the clinical diagnoses that ABM was previously proven to be effective for. Adults with generalized anxiety disorder, social anxiety disorder, and post-traumatic stress disorder are likely to benefit from ABM treatment. In children, ABM was tested in patient samples with anxiety disorders, generalized anxiety disorder, social anxiety disorder, and separation anxiety. It is important to provide the patient with a clear rationale standing behind ABM or ACT treatments prior to the first training session. An example for such explanation about ABM can be downloaded from our website. We recommend clinicians to review this material and verify that they are familiar with the treatment rationale. Controlled environment is important for an effective ABM session. The patient should be sitting comfortably in front of the computer screen. It is recommended to remove potential distractions during the ABM session. Electrical devices, smartphones, moving objects, noises should be avoided. To initiate a session, open the training program. Select the appropriate type of treatment. For anxiety disorders, select ABM. For PTSD, it is possible to use either ABM or ACT, as long as the same type of treatment is consistently given to a specific patient across treatment sessions. Click the Start button. When these instructions appears on screen, read them to the patient. Make sure that the patient understand the instructions before moving forward. From the second session onwards, the patient may read the instruction independently. Following the instructions, training will begin. It is important to sit at some distance from the patient and remain quiet, to allow focus and concentration during training. Finally, therapists are encouraged to maintain the recommended treatment schedule. That is, 8 twice-weekly sessions, with an interval of at least 1 day between sessions. We hope this information has helped you understand what ABM and ACT treatments are and how you could implement these treatments in your clinical work. We wish you success and hope that your patients will benefit from ABM and ACT treatments.